enter the critical territory of NSTEMI, the largest and most heterogeneous group of patients that we encounter. Our next speaker, Dr. Sudhir Koganti sir, is a senior interventional cardiologist at Apollo Hospital, Hyderabad. With broad expertise in complex ACS management, he will take us through the evidence on risk stratification, GRACE 2, TIMI, heart scores, and the crucial question of when a patient must be taken to the cath lab. Please welcome Sudhir Koganti, sir.
It's on the slide. Need change. Great. Good afternoon, everybody. I thank Raghu sir for giving me this opportunity. He's been a guide and mentor for me for many years, actually. I really congratulate him for setting up this educational session on a complex topic such as NSTEMI. And probably he gave me the most ambiguous talk in terms of risk stratification and also timing of invasive strategy. So let's see what we can do. Before I go into the talk, just a bit about me. It's not, first of all, I want to introduce myself, and also secondly, I did quite a few studies which I'm going to reference during the talk, and that's the reason why I put these slides on where I worked, be it the Royal Free, UCL, where I did my research at UCL, and also Georgios worked at Erasmus, but I think I went to Erasmus much later to him, and then where I did interventional training at Barts. And I've got this interest in cardiogenic shock, and always interested in what happens to the people who actually does not recover with our usual IABPs and impellas and ECMOs, and just to see the pathway, the bridge to transplant. I spent some time at Royal Papworth Hospital as well to see how they list these patients for transplant, and how they use the MCS, be it LVADs, Centrimax, and things like that. And with that, I spent quite some time at Citizens and now working at Apollo Hospitals in the financial district. So if you see, ACS is a spectrum. So basically there are only three entities when it comes to ACS. So you have your STEMI. The treatment protocols are pretty straightforward with this. You see a 10 millimeter ST elevation on the ECG. You take them for primary PCI, put in a stent or anything that is contemporary, job is done. But the most difficult set is the other spectrum, the non-ST elevation ACS. And in that there are two entities. One is unstable angina and the other one is non-ST elevation MI, and the difference is only elevation in the troponin. If the troponin is elevated, you call it NSTEMI, otherwise it's unstable angina, if you're convinced in terms of history. It's a very important entity, the whole NSTEACS. The reasons being outcomes, the strategies differ. They're not as straightforward as primary PCI in ST elevation MI, and there are a lot of financial implications as well. So if you look at the outcomes, this is one of the study showing that STEMI carries higher in-hospital mortality in the first 28 days, but later on, NSTEMI catches up. And if you actually exclude the first 28 days, the mortality with the STEMI is much higher in the longer term. And the main concepts in terms of management of NSTEACS is you need to have this abnormal ECG, the context, the clinical context, and also stability of the patient. Your invasive treatment strategies are time sensitive. It depends a lot on the stability of the patient. If you have an unstable patient, you tend to do it immediately, cath him immediately. Otherwise, you're going to take your time. And the invasive strategies are also based on risk stratification. If you have a very high risk patient or a high risk patient, probably you tend to do it much early. So this is that same pathway, showing it again. If you have a STEMI, it's straightforward. If you're NSTEMI, then you're trying to justify yourself taking them to cath by waiting for troponins, maybe doing an imaging, so on and so forth. So let's look at strategies. When I say strategies, What do you do in non-STEMI? Do you revascularize all three arteries? Do you do a complete revascularization at the index procedure, or you completely revascularize at all? So there is a data to show that complete revascularization in NSTEMI actually improves outcomes. This is a contemporary study which was presented at ACC recently and published in JACC Asia, and they actually showed that complete revascularization have got better outcomes when compared to incomplete revascularization. And they've also quoted one of my older study, even in way back in 2018, we did an analysis back then in London where we looked at complete revascularization STEMI. Those were the days when everybody was talking about complete revascularization in STEMI, and we've shown at median of 4.8 years, the group that underwent complete revascularization does better when compared to incomplete revascularization. And this paper is still referenced by, in any NSTEMI paper, and also it's included in the ESC guidelines now. So what about FFR? I know we use FFR in a lot of things. So this group looked at FFR-guided complete revascularization. That's got benefit when compared to only culprit-only revascularization. But as with FFR, the benefit is in reducing revascularizations, not hard endpoints. And let's take a step back and look at definitions or terms related to invasive strategy in NSTEMI or NSTEACS. Immediate invasive, wherein you take them straight to cath lab, maybe from ER, and then do PCR or CABG. Early invasive, when you do that within 24 hours. And selective, where you may differ or you may not do anything at all. You may just wait and see how the patients do. So if you look at this guideline chart by the ESC, so once you have your NSTEMI patient, on the top panel, you got your high-risk patient. These are the groups which are hemodynamically unstable. They have mechanical complications, they're in shock. Those are the people you need to take them to cath lab immediately. There's no doubt about that. So the level of evidence, it's got cut off, but it's A. So when you look at the high-risk group, this is where it gets slightly interesting, and let's look at the data. So back in the days, probably in the mid-2000s, there was this terminology that used such as routine versus selective invasive strategy. By routine, they used to take them patients to cath lab based on routine practice, or selective invasive. That means some patients may not even have undergone angiography or underwent angiography much later. And this strategy has shown no reduced all-cause mortality, but reduces the risk of composite ischemic endpoints, particularly in high-risk patients. And routine invasive strategy was also shown to increase complications if you intervene early. So this is a study by Mehta SR from Canada, the same guy who did the complete trial in STEMI. He had shown there's no big difference in death or MI if you take them to cath lab much earlier, but you definitely reduce ischemic endpoints and also probably angina and probably heart failure related admissions in the long run. Then came the terminology such as early versus delayed. Do you do them early or you do them slowly? You put them in the hospital, give you a 2B, 3As and take them to cath lab in 2 days, 3 days. Again, there's no superiority observed for early versus delayed invasive strategy in terms of mortality, but ischemia is better if you intervene early and the length of stay in hospital is shorter. So if you look at this meta-analysis from 17 randomized trials, so red is early and blue is all delayed, and see they're delayed all the way up to 4 days and early is within 24 hours. And if you see there's no big difference in mortality, but there are benefits in terms of recurrent ischemia and also future admissions in terms of heart failure. So those are the kind of endpoints which favor early invasive strategy. But there are a couple of caveats. If you have a patient with elevated troponin or a GRACE more than 140, GRACE score of more than 140, those are the ones which benefit with early invasive strategy, as shown here as well. with GRACE score of more than 140. If you have a very high-risk patient, if you do early, they do better than the delayed. But a low-risk patient, there's no difference in terms of outcomes. What about non-high risk? Absolutely, evidence is clear. You can do selective invasive strategy. You can wait. You can take your time. And as shown in this study as well, your low risk, there's no difference in terms of early versus delayed invasive strategy. So bottom line is, if you have a very high risk patient, ongoing ischemia, complications, take them to lab immediately. If you have high risk, early versus inpatient, depending upon GRACE scores versus troponins, non-high risk, selective strategy. So what about financial implications? This is another study which I did during my time at Royal Free Hospital. So we looked at, London used to have various pathways for NSTEMI. STEMI, just one pathway. NSTEMI, they used to go to a hospital with no cath lab. They used to go to a place with cath lab. Then they also had a STEMI type pathway where they were taken to cath lab immediately. So I looked at all those three pathways. You have a pan-London NSTEACS model where patients present to emergency, that is anywhere in with or without cath lab, then shifted to cath lab center, and then angio plus minus PCI within 24 hours of reaching this center, not from here. And then you also have ambulance picking up and then taking them to a dedicated center which was offering a pathway similar to STEMI type of pathway and undergoing angio PCI immediately. And then there was a third cohort who would go to nearby district general hospital cath lab and would find their way slowly to a cath lab in their own time based on the referral criteria. And when you look at the length of stay, this is in terms of this is in terms of time to angiogram, and these are the three pathways directly taken to cath lab. This is the pan-London pathway where efforts were put in to shift to center with cath lab as soon as possible, and then the conventional pathway. And your length of stay is much lesser if you are taken to through a direct access pathway to a dedicated center which would offer a STEMI type pathway. And when you look at the outcomes as well, there's no difference in mortality overall here. But if you see time to angiography, a large percent through direct access pathway would undergo angiography within 24 hours, whereas in conventional pathway, they would wait forever to get a cath. But overall, there's no difference in terms of mortality. So the median length of stay here was about 2 days. Here would be about 5 to 7 days. So with that, I'll just show quick couple of cases. First one is a 58-year-old gentleman presenting with a non-ST elevation MI, background of diabetes, hypertension, LV is good, no ECG changes, and he had a previous PCI2 circumflex and RCA. Now angiography showed significant LAD stenosis. So his GRACE score is 92 with a 3% probability of death from admission to 6 months. He's a low risk. And this is his angiogram. He's got a critical LAD stenosis, which was straightforward in terms of PCI, one regulating stent, and the diagonal was diffusely diseased, managed medically, and he went home on day 2. So let's look at second case, similar, almost similar type of history to the first patient, but only thing is this gentleman has got inferior ECG changes. That changes his GRACE score to 122, still not quite high risk, but definitely the mortality had increased to 8%, and his left system is normal, and he's got this critical RCA. And this again was straightforward, balloon stent, and this gentleman also went home in 2 days. So if you, both the cases, if you've incorporated LV function as a covariate into the GRACE score, their risk would go up significantly. So in summary, NSTEACS are a complex cohort, carry similar mortality to STEMI cohort, if not worse in the long term. Early intervention, if hemodynamically unstable, no difference in routine versus delayed strategy unless their GRACE score or troponins are very high, and complete revascularization definitely offers significant benefit. Thank you.
Thank you, Doctor. Question which can land us in medical legal trouble. Number one is that you admit a patient on a Saturday with an ST elevation, with a non-ST elevation MI, troponins are elevated. Next day being a Sunday, you put him in ICCU, like one of the cases, in fact, which the US Smith had shown. And we do the procedure on Monday, and some event happens on a Sunday. Where do we stand?
I think we commonly face this kind of situation. We do intervention straight away, don't we? If you see that on a Saturday, you're going to do it. You're not going to wait. But the guidelines,
late on Saturday.
That RCA, I capped him on a Saturday. And I didn't do PCI on Saturday. I did it on a Sunday. I mean, you haven't given antiplatelets. If he's stable, I think you can wait. Medical legally, they talk all nonsense, but it's very difficult to argue with the medical legal. But the guidelines clearly say if that guy is low risk, but his RCL looks really nasty. Anything can go wrong on a Sunday. But as long as I think you put them on antiplatelets, low molecular weight heparin, I think the events are going to be low.
Yeah, I think we should have Queen of Hearts insurance also. Actually, if you see, Shashi, I think there will be a paradigm shift with the development of AI. What our eyes cannot see, the AI will easily pick up. That's where the algorithm is going to change.
I understand that the first lecture was very, very good, but for the cardiologist, I mean, if we are on duty and we see an ECG which is borderline, I think my first step would be to take the echo probe. The first step would be to take the echo probe. What do you say, Dr. Sudhir?
Yes, definitely.
That's the fastest and the quickest.
But the problem is the capability, the bandwidth of the echocardiography, the ability to do the echocardiography. I think in current cardiology, the casualty is echocardiography.
And the ability.
It's a big casualty in current cardiology is echocardiography. I think it's more clinical. It has become more clinical now. AI for echo, yes, I will agree, but not human.
Sudhir, maybe in all NSTEACS we should roll out an OMI.
OMI, yeah. That's what Sudhir was preparing for his talk. So, OMI versus NOMI, that is the concept which is going to change the way how we manage it, I think.
Many times we think it's an NSTEACS, but
it's actually a occluded vessel.
Especially for the circumflex, it's quite common to get this sort of a normal ECG, typical chest pain, prolonged chest pain.
Or you don't see ST elevation.
You don't see an ST elevation, and it's the circumflex which is occluded, which is poorly represented on the ECG also.
Poorly represented for our eyes.
Agreed.
somebody sends you an ECG, you're trying to avoid the angioplasty, or all your senses are...
Yes.
With AI you won't have that.
You don't have that option. That's why Dr. Cianos left, no? So, anytime when I call Cianos, there is no way he sleeps at night. All through the night, they have to be awake, all through.
Well, that's his on-call day, but for us, it's every day,
Every day,
yeah.
Every day for minimal things. That's not for maximal things. I think, we will have to.
Now can we have Raghu sir facilitate Sudhir sir?
Go on.